to this Meet the Expert session. We have Dr. Lorenzo Grazioli and Dr. Matteo Brivio, who are working at the intensive care unit in the Bergamo Hospital. We're headed by Professor Lorini. Welcome, and the theme of this discussion today is ECHOS, an acronym that we have created some time ago, defining extracorporeal organ support therapy, which means by just modifying the extracorporeal circuit, you can somehow create organ support, not only for the kidney, that was the original design, but also for the heart, the lung, the liver, and possibly other situations, including sepsis. Of course, this requires the application of different devices like oxygenator, decarbonizers, sorbers, and sorbent cartridges. In addition, most of the time with a typical dialyzer supporting kidney function when acute kidney injury occurs. So my first question to you is, what is the platform that you are using for these different techniques?
Hello, everybody. I'm Dr. Matteo Brivio, and we use the BBRAUN OMNi machine, which is a very interesting platform because we have been involved from BBRAUN very early in the development of this machine from the very beginning, and we gave them our suggestion to develop it. Is a multifunctional platform which is able to perform a CRRT, but also CO2 removal and sepsis treatment with specific cartridges. So it's very useful in our clinical daily practice.
So this machine is, I like what you say, because you define this as a platform, and this was the original idea when we had the consensus conference in Brussels with Jean-Louis Vincent on extracorporeal organ support therapies. We wanted to create a unified platform, avoiding additional circuits that can interact in a negative way. Plus, this machine, and I am particularly I have affection for this machine because the original prototype was designed in California at the Transvivo company, a company that doesn't exist anymore. So, and in our museum we have the grandfather of this machine. But the beauty of this machine is exactly the multifunctional approach. So, for example, first of all, when you use CRRT, there is an interesting feature, which is the catch-up of the dose. If you discover you are underdosing the patient or you have unexpected interaction, the machine can somehow catch up. Can you describe this function?
Yes, the machine is very feasible in this pathway because it's got a kind of dynamic adaptation on patient support. So if there is, for instance, back changes or unexpected moving of the machine, so interrupted by, for kind of minutes, the machine increased the dose for some time and catch up with the dose. Do not underdiagnose the patient during the treatment. It is very useful in intensive care where the patient are moved, are cleaned, you had to add catheters, or you had to do chest X-ray or whatever.
Did you experience this during the prone positioning of the patients with COVID-19?
Well, yeah, we experienced the machine with prone position during CRT and also carbon dioxide removal. Of course, the carbon dioxide, what we removal we want to achieve is CO2 removal and not only the CRT. During the prone position, the problem can be, of course, the position of the catheter and the interruption of the flow. Yes, we experienced that, and it was very useful.
What kind of catheter do you use normally?
We use 12 French aero catheters, even in internal jugular or femoral vein, and also for when we do perform CO2 removal, we use a larger catheter, normally 13 French, yeah, to achieve an adequate blood flow, which is around 300 and a half milliliter.
So you do CO2 removal with a blood flow of 300, 350, not greater?
Even greater to even to 400, but somehow in some cases 300 and a half in our experience is quite enough to remove 15, 16 milliliter per minute.
So let me ask you, in this case, in the machine, there is a circuit where you have the dialyzer and the small oxygenator, right?
Yeah.
Now, which type of patient do you recommend for CO2 removal?
Well, CO2 removal is a kind of pathway, is in the between the conventional ventilation and ECMO. So we have used CO2 removal during COVID as a bridge to ECMO, for instance, or to reduce the ventilation support in patients who have pneumothorax or that have the need of reducing the tidal volume.
Also, aggravation of chronic obstructive.
It can be a good option. Also, because the right ventricle of this patient is already loaded by the pressure. So if we can reduce the CO2 without a big load of the ventilator, right ventricle cannot fail.
So basically, some patients, you may try to use it to avoid intubation. In some patients, you use it to create what we call ultra-protective ventilation, basically, with very low tidal volumes. Now, it's interesting that the platform also allows to utilize sorbent cartridges in the circuit. We, and probably you, had interesting experience in case of sepsis. So what was your experience with sorbents in sepsis and possibly also in COVID-19?
We used all sorbents or cartridges which are available for the OMNi machine, which are the Alteco LPS adsorber, the Jaffron cytokine adsorber, and the cytosol. We use them in COVID patients and also in septic patients with very interesting results. I remember, for example, an interesting case, a COVID patient which developed a profound myocardial dysfunction due to a bacterial superinfection. It was suffering from a bilateral pneumonia, and he suffered from a bacterial superinfection. And we started very quickly with the Alteco cartridge support, and in a few hours we could slow down the vasopressor and also the epinephrine dosage. and myocardial at the echocardiography, we could appreciate an increase in myocardial function, which was surprisingly rapid and quick.
Yeah, the interesting aspect related to application of this technology in sepsis is that the patient changes every half an hour with the hemodynamic characteristics, etc. For this reason, we have advocated the use of what we call sequential extracorporeal therapies. I don't know if you know the concept, but basically, and even more now, because you have the possibility to remove pathogens. So today we have, for example, Seraph 100 of Xtera system that allow you to remove viral particles or bacteria. Then you can have the Alteco orthorimixin that allow you to remove LPS, which is the trigger for the impending cytokine storm. Then you have cytokine removers, for example, the Jafron HA380 or the Cytosorb. And then you have the possibility also to use CRRT with membranes that now have capacity of removing, in part at least, and also absorb some cytokines. But the more efficient system for cytokine is definitely the Sorbent cartridge. So one of the questions that we have always debated is, what are the criteria to shift from one treatment to another? For example, for LPS absorption, we have today endotoxin activity assay, so we can measure that. For the other situation, do you mostly use hemodynamic and clinical criteria, or do you use a measurement of cytokines?
Well, it is difficult sometimes to decide on something that has to be measured because the patient is very, very critically ill. But for instance, during COVID, we, especially for ECMO patients who need CRT, we have measured EL6, interleukin 6 level to decide when change the cartridge and put another one or stop the treatment.
How long do you use hemoadsorption?
Usually, it depends on what we had in front of. Usually 48 hours is the right time to assist an improvement on our patient.
And you do continuously?
And we do continuously, yes.
What kind of anticoagulation do you use?
Well, it depends. Because we are a cardiosurgery unit, on medical patients, we like to use heparin, but of course, in surgical patients, we have to use citrate.
And in some patients, you don't use any anticoagulant, I assume.
Yeah, because they are very, very close to the intervention, so it's very risky to use.
The interesting thing we have observed is that these sorbents, compared to the past, they do not really cause a drop in platelets, albumin, and so on. Is your also observation?
Yeah, we don't see any more drop, especially in albumin, because they're very, very conservative.
And so the machine allows you to do all these treatments and allows you to do different type of anticoagulation. So it looks like it's a very flexible equipment. Do you have any particular problem in training the nurses to use it?
Well, of course, when you introduce a new machine in a unit, you have to do some training, of course, but apart of that, as soon as you know the machine, you essentially overcome all the problems.
Certainly. I think that one of the last questions I would like to ask you is, do you think this machine is adequate in case we want to design, for example, a randomized trial? I have to tell you that I'm not particularly in love with randomized trial for these patients, because first of all, it's difficult to select the endpoints, and then it's difficult to define the patient characteristics. But in general, do you think it could be interesting from the possibility of recording the data? This is my question.
I think it could be very interesting. The machine is very capable in this light, because it's quite new and modern, and it could store all data we do need to perform and to record a database. So it could be the right machine to use, I think.
And this, I think, is important, because more and more we will rely on registries, on retrospective analysis of data collected, possibly with the use of artificial intelligence, etc. But in general, looking at the real world application of these techniques. Well, time has come for us to close, and I really thank Dr. Grazioli and Dr. Brivio. It's nice to see you again, because many years ago I visited your center when Professor Parenzan was there and many others, and we did one of the first hemofiltration in the neonates over there. So you probably were not born yet at that time. So thank you very much.
Thank you very much.
And thank you, thank BBRAUN for sponsoring this interesting event.
Thank you. Bye.
Thank you. Thank you.